I want to start by saying good afternoon. Thank you so much for joining us today for our third edition of our Inspiring Speaker Series. My name is Michelle Curie, and I'm the CEO of Compassion House Foundation, and we proudly operate on Treaty 6 territory, the traditional meeting grounds and home of many Indigenous peoples, including the Cree, the Saulteaux, the Blackfoot, Métis, and Nakota Sioux peoples. Here at Compassion House Foundation, our mission is to support women through the cancer journey, and we do that by providing safe, comfortable, and affordable accommodations at Sorrentino's Compassion House, as well as a variety of post-treatment programs and services, including workshops and retreats, local in-person support, online resources, including things like today, and Compassion Connects. While our past sessions have been mostly focused on the experience through cancer treatment and recovery, today's speakers will talk about the importance of regular screening and early detection. We're thrilled to have Dr. McKerlie, a radiologist with a passion for breast imaging, who's worked in the area for 17 years, along with Marina Rosta and Karen Stroebel, both past guests of Sorrentino's Compassion House, here with us today. I'll turn it over to them really shortly here. Dr. McKerlie is going to go first. She has an excellent presentation for everyone. And then we're going to have Marina, and then Karen will close, and we will have some time at the end for Q&A. If you would like to type questions in to the chat box or through the Q&A section as we go throughout, I'll hold on to those and read them out at the end. Now, without further ado, I'd like to turn it over to Dr. McKerlie.
All right, I'll share my screen. Hi, everybody. Let's see, share screen. Can you see? Can you see my screen?
Yeah, we can see it. Perfect.
Awesome. Okay. Thank you for having me, Michelle. Thanks for that introduction. It's my honor to be here today on behalf of the Compassion House Foundation, talking about the importance of screening, mammography, and ultrasound. So let's get started. I'm dedicating this talk to those that have fought and won, those that have fought and lost, those that are currently fighting, and stage 4 patients. So breast cancer, it's the most common form of cancer for women in Alberta. It accounts for about 25% of new cases of cancer and 13% of all cancer deaths in Canadian women. 1 in 8 women is expected to develop breast cancer in her lifetime, and sadly, 1 in 33 will die from it. Mammography is the recommended method of screening for women in the average risk population. And I mentioned average risk because that's the majority of women that will develop breast cancer. 75 to 80% of breast cancers occur in women that don't have a family history. So it's important for us to be able to detect it. A screening mammogram is essentially a mammogram in an asymptomatic patient. It's something that occurs periodically every 1 to 2 years. And why do we want to do it routinely? Because when we do it routinely, it's an opportunity for us to detect cancer or pre-cancer early before it becomes symptomatic. We want to get it when it's most amenable to treatment. So the smaller, the better. And when it's treated, you will have less comorbidities. The big question, when should I start getting mammograms? Well, there's so much information out there. There's so much conflicting information. Is it 50? Is it 40? The last person I talked to said they asked their family doctor and they couldn't get a straight answer. So there's so much confusion. The reason for the confusion is that there are so many bodies out there that are making these rules. I mean, I've listed a few and there's so many more. In Canada, the recommendations for screening are largely based on the Canadian Task Force for Preventive Care. And I'm not going to get too much into this because it's a big topic, but there are a lot of flaws in that study. They do acknowledge that most lives are saved if we start mammography at age 40, but they talk about the theoretical risk, possibility of overdiagnosis and false positives. Again, that's a whole nother story. I'm not going to get into it. A lot of flaws in the study regardless. In Canada, the information differs from province to province. There are 3 provinces that recommend starting mammography at age 40. 7 recommend starting at age 50. Out of those 7, 3 of them will start women at mammography at age 40 if you get a referral from your family doctor. And Alberta is one of those provinces. For your first mammogram, you need a requisition from your family doc. And after that, You can come every year without a rec if you're asymptomatic. Practically, we follow the top guidelines towards optimized practice, which says that under 40, we don't recommend screening. If you're 40 to 49, again, there's that discussion. And notice what it says here. If you do decide to get screened, you should be screened every year from 40 to 49. Whereas if you're 50 to 74, every 2 years. Isn't that interesting? So from 40 to 49, we want you to be screened every year. Why is that? Well, the reason is because, practically day to day, we see a lot of cancers in that age group. Those cancers will tend to be higher grades, grade 3. They may grow faster, so we want to catch it. In Caucasian women, the incidence of mammography peaks in the 50s. In Blacks, in Asians, Hispanics, it peaks in the 40s. So we want to catch it earlier rather than later. For that reason, most radiology practices in Alberta will follow the ACR guidelines, which recommend starting annual mammography at age 40. So be informed. Keep calm and be informed. Know the risks. Make an informed decision, recognizing that women with routine screening mammos starting at 40 are 40 to 40% less likely to die of breast cancer than women who don't. And we're more likely to find it smaller, so less aggressive treatment if the cancer is found early. Okay, so we answered that question. Let's talk about what's involved in getting a mammogram. We get 4 pictures. So 2 of them are from the top. So this is a craniocaudate view. We get a right and a left. Looks something like this. 2 of them we get from the side. That's an MLO view. All in all, we get 4 pictures. And that's it. Now, that's average. Why do we want to do this routinely? Because size does matter. It matters because the smaller it is, the better. This is the average size of a lump that's found by getting mammograms regularly, 1.1 centimeters. And I Googled the average size of a P apparently is 8.5 millimeters. So we can find cancers way smaller than that if you're doing your mammograms routinely, as opposed to if you just kind of find it by accident, 3.6 centimeters. I think most of us would want to be over on this side, right? Here's an incidental example of a patient that was 44. She came in for routine mammography. There are 2 areas that are seen laterally, and I've outlined them there. So there was a mass that was 9 millimeters. There was another mass that's 3 centimeters. So that's the cancer right there. There was a lymph node that's abnormal, it's thick. This was a grade 3 cancer. So this is what we don't want. We want to see a situation like this, where this is a 46-year-old who's been coming. This is her in 2017, 2018, 2019. I'm not sure why the dates aren't showing, but here we can see, I can see that there's a change right here. And that was a 1.2 centimeter breast cancer. So this lady's breast is dense. It's a good time for us to talk about breast density. What is breast density? This is a radiographic description. Some people come and say, oh, my breasts are dense. I feel like they're dense. It's not something you can feel. This is something that we tell you radiographically. So I'll explain what that means. 4 images here, going from the left to the right. I want you to notice the amount of white in these images. So you'll see that the fatty breast has more black. The scattered, you have more white, even more white on heterogeneous, and yet more white on the dense breast, okay? Why do we care how dense your breast is? Attention was called to this by Michelle de Tomaso, who was diagnosed with breast cancer in 2014. And she was told that the cancer would have been diagnosed earlier if she had maybe had further imaging like ultrasound, because her breasts were dense. It was missed. And so she's really passionate about seeing breast density notification for women to know how dense their breasts are and for us to include it in our letters to patients. She is a co-founder of this nonprofit organization, and I've put their website there and their Instagram handle. And they raise awareness about the risks associated with dense breast. Right off their website, density matters because the denser your breast is, the higher the risk of getting breast cancer. In fact, having dense breast is a greater risk than just having a family history of breast cancer. And mammograms miss about 50% of breast cancers in the densest breast. So important again, because I see a lot of patients and they'll be like, this is not in my family, there's nobody in my family. Most of the patients we see do not have a family history. And having dense breast is a higher risk factor than actually having a family history of breast cancer, okay? So here I am telling you, have routine mammograms, but then a mammogram could miss breast cancer on a dense breast. Why is that? Well, when we look at mammograms, pathology, whether it's good or bad, we see it as white. Cancers are white on mammograms. So you can see how if you have a fatty breast, such as we have in this patient, this is all black, we have this white spot here, that's a cancer, I've zoomed it up. This is a 1.4 centimeter cancer. Here's another patient, right and left. Notice this little spot here, that's it zoomed up right here. This was a patient a year ago, current. You notice the difference? Easy to see. This was an 8.5 millimeter cancer. That's our needle going through biopsy. Yeah, invasive ductal carcinoma. So why is it difficult to see? Here's a fatty breast, and I'm going to pretend to put a cancer on there, right there. You can see how it stands out on the background. Now you're gonna watch me put it on a dense breast, it's right there. I think you can appreciate that it is a bit harder to see in that background, right? You watch me do it so you can see it, but on a routine basis, it's harder to see. So what do? Well, we've come a long way. We've come a long way technologically. It used to be that as radiologists, mammograms were looked at on films. So we see this radiologist here, she's got her films lined up. We use a magnifying glass and look, she's hunched over, you know, she's not even smiling. Then we have another lady here, she's sitting straight, she's smiling, she's on the computer. This is digital mammography. And then we've heard of 3D tomosynthesis. What is that? It's even better. So this is a routine mammogram before 2D. The breast is compressed and we get our 4 pictures. Tomo, same thing, the breast is compressed. You have a camera that sweeps over that breast. And I want you to notice what happens here. We can kind of sweep through and it's almost like we're slicing through that breast. It's compressed and we can see through it. So this is awesome because it really helps us see, I hope this is, let's back up. It helps us see so much better. And it's really good, especially for ladies that have category C, which is the heterogeneous, and those that have dense breast tissue. And another thing that it's good for is, you know, back in the day, you'd have a mammogram and then you'd have to get that dreaded call. You need to come back for an additional view. With tomosynthesis, it happens way less often, okay? What else can we do? Well, that's where ultrasound comes in. Ultrasound is a way of using sound in order to determine the characteristic of the tissue. We can tell if a lesion is solid, you're feeling a lump, is it solid? Or is it filled with fluid, cystic? And it also allows us to do something about it, to do a biopsy. Most of us are familiar with handheld ultrasound, which is, you know, you go have a baby, you go have an abdominal ultrasound, you have a technologist that's sitting there, they're doing the exam for you. But then most people have started to hear about something called ABUS, or whole breast ultrasound. This is essentially the same thing as a regular ultrasound. The only difference is you have this machine, you have a technologist that takes the machine, it's placed over the breast, and the machine takes all the images. So it looks something like this. We get a nice 3D view. In this lady, this is the nipple right here, and this is the cancer. And essentially what happens is when there's a cancer, then it's converted to a handheld so that the radiologist or the technologist can look at it even, you know, further. So those are the 2 different ultrasounds. So then the question is, because I get this a lot, why can't I just have an ultrasound instead of a mammogram? And I get that, especially perhaps in women that have implants. Why can't I just have an ultrasound? Now, if you remember, I said success looks like us finding that cancer early and without it being in a nose. There's something called DCIS. That's a precancer. We want to find this because these cancers will inevitably, these calcifications or DCIS will inevitably become invasive. And it manifests, we see it on the mammogram as calcifications. 90% of cancers present as calcifications or masses or both. Here's a lady that's 44. You can't even see anything here. I can tell you she's got some calcifications right here. They look something like this, right? These little specks of white, that's it there. We biopsied it. You can see that we've got the calcifications. This was a high-grade DCIS, and she's already just started to early get micro-invasive carcinoma, minute foci. This is good. This is what we want to see. We want to catch it early, okay? So why not use breast ultrasound alone? Well, yes, ultrasound doesn't use radiation, and yes, adding it reveals more cancers, but 83% of DCIS cases were only identified on mammography alone. So we want to use a combination of both. We want to use it to characterize lesions, use it in dense breast, to supplement for high-risk patients like BRCA1, 2, people that have had lesions biopsy that are higher risk. So example, this is it's not an example, like we use it for intervention. So this is a pregnant lady who came with a palpable lump. It was a plugged milk duct. So we were able to put a needle in there and drain it, okay? So we're able to do things with ultrasound. Same with radiation as well. Brief comment about MRI. Yes, we can find a lot of cancers with MRI as well. It is not a routine screening tool for the average risk population. It's more for the higher risk population. And I cannot end this talk without talking about thermography, which is using infrared. The Society of Breast Imaging and Health Canada reminds us that thermograms are not a substitute for breast cancer screening, okay? Just pointing out that female breast cancer death rates have dropped by nearly half since the mid-80s, and that is largely due to the positive impact of screening programs in breast cancer. In Canada, we are very fortunate to live here. All the provinces except one has a screening program, and that is the highest, that's the province that has the highest cancer mortality rate of all the provinces. So that should tell you something. So in summary, mammography is the recommended method of screening for women in the average risk population. We start at age 40 as per CAR guidelines. Breast density does matter. The denser the breast, the higher the risk of breast cancer. And ultrasound is a supplementary exam to mammography. I want to say thank you to all the techs and sonographers who make it possible for me to do my job. Lots of times you guys come for mammograms and ultrasounds, and we get these people that, these magical fairies, I call them, that get these wonderful pictures for us. I'm able to do my job because of them. Thank you. And thank you to the Compassion House Foundation for inviting me. That's it. I will stop share.
Awesome. Thank you so much, Dr. McKerlie. That was a lot of really good information. I'm sure we'll have a lot of questions at the end for you. So we're going to hold off on questions until the end, but if anyone does have them, you can pop them into the chat box on the side there, or use the Q&A function across the bottom, and we'll just hold off on that until the end. But now we are going to turn it over to Marina Rosta, who is a past guest of Sorrentino's Compassion House, to share her experience with early detection. Marina, you just over here. Yeah.
Sorry, I'm on this. Yeah, I don't have any buttons, but it did give me instructions on how to get myself on here. So first of all, I just want to say thank you for inviting me. And that was so informative. Thank you, Dr. McKerlie. It was very interesting. My experience, I did write it down so I wouldn't forget too much. Was probably similar to very many women. I was 54 when I was diagnosed, and that was my first mammogram. So from that, I will tell you how it went. As with all women who are diagnosed with a potentially fatal illness, I was in shock, and certain of my reactions were probably inappropriate at the time, but then that's why it's called shock. I had found a lump in my breast months earlier. I had made 2 appointments to have it checked based on friends' insistences, but canceled both as I had more important things to do. When I finally did go, the lump was slightly larger. It was very hard and it did not hurt. I honestly thought absolutely nothing of it. I had had cysts before and they were always benign. In the back of my head, did I ever think lump cancer? Yeah, but it was soon dismissed by my logical self. As the doctor said, I had no history of breast cancer in my family, so that was something that was always playing in me. I was athletic, I've never smoked, I've never done drugs, I eat healthy, I drink distilled water, I take vitamins, and I have a great outlook on life. So what were the chances? So along comes the date for my mammogram. My doctor suggested it because I had this lump. Now, I live in a remote town in the Rockies, so getting out to the city is always a big adventure and something to which most of us here in Jasper typically look forward to. It means shopping. Now I'm getting to be a great shopper. As a matter of fact, I'm not a great shopper. I hate it. However, I do like getting new clothes. So that's what it was all about. It was going to get new clothes, and this little appointment was just kind of an excuse to get out and get off work. Wrong. So I go in and submit myself to a very painful exam. I have breast implants, so it's a little bit different. They pull your skin and they twist it into the machine and flatten it down. So it was quite painful. And then I was left alone on the examination table. After my examination, about 3 minutes later, a doctor appeared. She wanted to do an ultrasound. So now I'm starting to get a little concerned. Still, I thought, okay, they're just being cautious. That's their job. Once I'm done, it'll go away and I'll be told to go and finish my shopping. Now the doctor wants to do a biopsy of my little lump. So now I'm starting to really get anxious. This is cutting into my shopping time and most likely very unnecessary. The doctor took 3 punch biopsies. Once done, they bandaged me up and told me to wait on the bed. It didn't take long and the doctor came back in. I told her straight up to let me know what she was thinking. I told her not to sugarcoat it. I do have a nursing background. So just give it to me straight. And her exact words were, "It looks very suspicious." So what's next? I asked. The doctor told me she would send me the results to my GP, who would call me and confirm. At that point, I was allowed to go. I didn't know at the time, but the doctor had already phoned the Cross Cancer and registered me as a patient. So now I had to try and enjoy my shopping day. And needless to say, there was a big cloud hanging over the rest of my day. And now I was beginning to have all kinds of thoughts, which I would never typically have. Will I need treatment? Am I going to die? What am I going to tell my kids? I don't recall my drive home at all. I got home, I was exhausted, unpacked my purchases and went to bed. I got up and I went to work in the morning. I arrived at 8 a.m. 8:30, I received a phone call from my GP here in Jasper, who said he wanted to see me in 10 minutes. I arrived at the clinic and was let straight in. "I'm so sorry, Marina, it's cancer." Words I'll never forget. I went back to work and I didn't tell anybody. I worked the remainder of the day. When I got home, I told my children and we cried. And there my journey began. So my message to everybody is, whether you're allowed to get it at 40 or at 50, and in Alberta, if you're allowed to get it at 40 and you have any concerns, do go, because mine was a grade 2, grade 3 being the most aggressive. Had I gone when I was told at the time it was 50, I wouldn't have had to go through the surgery. It wouldn't have been invasive ductal. I wouldn't have had to go through 25 rounds of radiation treatment. Chances are I would have had a little operation and that would have been the end of it. But I did wait. And the mammogram, even though I waited, at the end of the day, did save my life, because I am cancer-free now.
Thank you so much for sharing, Marina. And we're so grateful that we've been able to be a part of your story and journey through this. And I remember the first time I met you in the kitchen at Sorrentino's Compassion House, and I was just like, who is this fabulous woman with this like beautiful hair so put together? And hearing you play the piano in the house, and I know it was really hard on you being away, especially over Christmas, but you know, I'm glad that if you had to be in the city, that you could be staying at Sorrentino's Compassion House and surrounded by the women that you were during that. And I know you've become such a great ambassador for the house and have remained in contact with with so many of the women. And even just before we started here, you're talking about how impactful it has been for you to hear other women's stories. And so for you to give that to others who are here as part of this today, I think is really impactful as well. So we really appreciate it.
My pleasure.
So I'm sure there's probably questions that people have, but again, if you want to, you can throw them in the Q&A box or in the chat box, and we'll attend to those at the end. But I do want to give everyone an opportunity to speak. So we're going to pass it over to Karen Stroebel from Grand Cache to share a little bit of her story with us.
Hello, everybody. I'm really excited to be here today. And I've got some notes as well, because this experience has so many layers, and you can go down the rabbit hole quite quickly. So I'm very happy to be one of the many faces of women that moved through a screening journey here. And thank you, Marina and Dr. McKerlie. That was amazing. My ultrasound radiologist might want to turn her screen more away from me. She's a little protective when I show up in her room. But I have a science background, so that's the problem. I have no history of breast cancer in my family. The only person that developed breast cancer was my grandmother at 70 years old. And that wasn't really considered a contributing risk factor to me developing breast cancer. I was diagnosed at the spry young age of 55, which I guess is officially middle-aged, but I don't feel it. I was diagnosed with stage 2 invasive ductal carcinoma. I'm hormone positive, both for estrogen and progesterone. And my breasts and I have had quite the relationship over the years. I was about 19 when I had realized breast can harbor lumps and bumps, and I had discovered 3 cysts in my areola when I was 19 years old. And this is 40 years ago. So they aspirated it, and they were diagnosed as a chocolate cyst. So that got me curious about breast self-exams. And the breast self-exam for me was incredibly frustrating, because it's not that I had dense breasts, but I had, I guess it would be called cystic breasts. They were very lumpy. I could find things all over the place. So that was really frustrating for me. So I decided to focus on the big 4. And so the big 4 for me was skin changes, the puckering and the redness, nipple discharge, red, green, clear, nipple flatness, inversion, and whether or not I had a match set. So if one of the breasts were looking a little different than the other, then I would go to the doctor. So, because breast self-exam for me was so frustrating. So in my early 30s, I was diagnosed with endometriosis. And what ended up happening is my relationship with the breast became a little more complicated, in that they ended up being much more painful and much harder to do a self-exam during the month. So I ended up having a green discharge from my nipple. I was about 38, so I was on the cusp, as Dr. McKerlie said, of 40. So my GP requisitioned the mammogram for me. And then what ended up happening from 38 moving forward into my 40s, I was scheduled. At that time, it was every 2 years. I understand now it's every year, but back then it was every 2 years. And in my mid 40s, my right breast took a break, and my left breast got involved. And mammos had discovered a shadow near my chest wall. And so I ended up having increased surveillance, where I had to go every 3 months. And that was basically for the ultrasound. And I would have a year of surveillance every 3 months. And then once things were static, or that abnormality that they were concerned about disappeared, I'd be kicked back into the normal surveillance cycle of every 2 years. And on 2 occasions during that 5 years, I ended up having to be referred to a hospital diagnostic mammo. And in my mind, that's the bad boy. That's it's amazing what they can do with the diagnostic mammo at the hospital, in terms of, like Marina was saying, of the twisting and lifting and pulling. And so March 2019, an abnormality was found in a mammogram. July 2019, I was sent for ultrasound surveillance. and recommended for increased views. And it was approximately 4 or 5 month intervals. Then in December, I had an ultrasound of the right breast and the abnormality was still there. So my recall was going to be May of 2020. We all know what happened in March of 2020. So I had no idea what my mammogram status was going to be. I had no idea what was going to happen to me. So in April, because I had a series of already 3 or 4 mammos and ultrasounds that were still showing an abnormality, the Grand Prairie Hospital actually called me to go and get examined with a diagnostic mammogram. And at this point, I've already had 2 or 3 ultrasounds plus the mammo for the abnormality. My local doctor is phenomenal. He phones me regularly with an update. He phones me regularly with a referral, and he does the liaisoning and the requisitioning for me. And because I'm in a remote community, Grand Cache, he's really lifted me up. And no guarantee I won't get emotional either, because so May 8th, I have my date with the bad boy at the hospital. I had the mammo in the morning. In the afternoon, I was sent to the ultrasound at the local diagnostic center. 1 week later, I was sent for a core biopsy. I have to travel 5 hours to get to the medical specialist. Within a week of that core biopsy, I was diagnosed with breast cancer. 5 days later, I had the surgical consult. What was interesting is I realized through all the testing and screening, the mass was at 7 o'clock on my right breast, which is lower and under. I couldn't feel it. I couldn't feel it. The surgeon who did the consult couldn't palpate it. So it was the screening mammogram and the intense level of surveillance that helped find it for me. It wasn't, so I'm really grateful for, within 2 weeks, I was in having a breast lumpectomy. Within the 6 weeks or 8 weeks, I was assessed, I was graded, I was staged, I was operated on, and I was heading into chemo. And I'm so grateful that my treatment happened so quickly in spite of COVID. So the next part of the journey is a little bit COVID related. As many of us know, the Grand Prairie chemo clinic is very small and you're not allowed to have support people there. The hospital had intermittent breakouts, and then there was really rigorous COVID protocols. So my breast lumpectomy, I had to go through that alone. My husband was able to pop in and pop out, but I was on my own. And then in January here, I had my second surgery, and it was a drive and dump. So drive up to the front of the hospital, a kiss, and good luck. And into the hospital I went for my next cancer-related surgery. It was amazing to me how quickly my status had changed in 6 months from just having an abnormality under surveillance to being diagnosed with stage 2 breast cancer. I had experienced multiple times in my 40s and 50s, increased recalls, 3-month intervals, 6-month intervals, and it felt like I was crying wolf. It felt like my doctor was crying wolf. I was getting stressed out by the frequency and also the different facilities that I had to travel to out of Grand Cache for screening. And the only time I experienced an ultrasound biopsy was after I had the diagnostic mammogram in Grand Prairie. So I completed 25 rounds of radiation and stayed 5 weeks at the phenomenal Compassion House. It was a place in the COVID pandemic craziness that I didn't feel alone. I was sheltered safely, and there was other people navigating a cancer diagnosis during the pandemic. I wasn't able to pick up prescriptions, grocery shop, have visitors, or travel to my family during radiation in order to maintain the integrity and virus-free status of Compassion House, which ultimately protected the Cross Cancer Center. So I was alone without my usual supports for grounding, for human touch, for comfort. I had to flash my breasts weekly over video for my radio oncologist to view due to COVID protocols. I felt like I had descended into a B-grade porno. It was a secure line. The nurse and my radiologist incredibly kind and compassionate, but it was just surreal, and I was so vulnerable. And so cancer and the unknown, it's not tangible. I don't understand why luck or fate or estrogen dominance triggered my cancer cells to have a party, but it has life-altering outcomes. And then during my cancer diagnosis, it was compounded by another unknown, and that was COVID, which also could have life-altering outcomes. So Compassion House and the women from all walks of life were a touchstone during an incredibly vulnerable, disorientating, humbling time. Those Compassion House sassy sisters, and there were some phenomenal men that were there as well, lifted me up so many times. They provided stories, advice, shared cancer, COVID experience, and laughter. Sometimes dark, sometimes over the top belly laughter, but I'm so grateful for this opportunity to share my story, and I hope it lifts somebody up to get their caboose in to start their own surveillance journey, because my cancer wouldn't have been found as quickly as it was, and it was under rigorous surveillance. So thank you for this opportunity to share this forum with everybody.
Awesome. Thank you so much, Karen. And like, what an incredible story from 19 all the way until now, and kind of monitoring that. And I think really just that experience of feeling like you're crying wolf, right? Like going in and that constant surveillance, but the importance of it, especially if there are different factors there. So I really appreciate you sharing. I'm so glad that we were able to be a part of your journey, and that you've stayed in touch with us as well, and your willingness to come here and share. I think it just is that really important reminder for people that, you know, it's not just an ad out there, it's real people and real stories, and that this could be anyone. And so the importance of getting out there and starting your screening, especially if you're at that age, is so, so important. So thank you. We do have a few questions, I think, coming in here. So I'm just going to quickly pop this open and see what we got. So how do I know if okay, this is from the same person. So I was diagnosed with breast cancer in 2016. I had 2 surgeries as the margins were not clear. I've had 16 radiation treatments. How would I know if I have dense breasts? Should I be having an ultrasound in addition to mammography yearly? I'm 65 years old.
I can take that. So you will know if you have dense breast because of the, so interesting. So women get letters to remind us to get mammograms when you have no issues. If it's a diagnostic mammogram, you don't get a letter. However, the report of your mammogram should say, you know, the parenchyma is fatty or heterogeneous or dense. So this is a simple question to your family physician. What does that letter, the mammogram, say? And the ultrasound, yeah, we can see, you know, when we do an ultrasound, yeah, the tissue is dense, but you really get it from the results of your mammogram.
Awesome, thank you. Next question is, should women who have had a mastectomy still get a mammogram to check the chest wall, or is an ultrasound alone sufficient?
So a small percentage of women, about 5%, will get a chest wall recurrence within 10 years. Some centers do the chest wall views routinely, some don't. And the thought process, especially when you talk to surgeons, is when the breast is gone, you're just feeling your chest. So you should, if you are doing routine breast exam, which is still important, you should be able to feel the change, right? If there is at all any tissue there, the technologists will image it. So I hope that answers the question.
Thank you. And we had
alone is not necessarily enough.
Perfect. We also had a question in regards to should men or can men go for a mammogram?
So males do get breast cancer. It's a small percentage of breast cancer. 1% of all breast cancers in men, of all cancers in males are breast cancer, and I've done a few. Because of the low percentage, it's not a routine screening type thing, but yes, males do get breast cancer.
And then another quick question was, how do breast reductions affect mammograms and or ultrasounds?
Usually when I look at a mammogram, I can tell, oh, this person had a reduction. The reason why is because the breasts almost look kind of messy. It's kind of a swirl, but it doesn't matter. You know, what having a reduction does is give something called architectural distortion. Distortion is just messy. The things that can do reduction, that can cause distortion, are previous surgery for whatever reason, and cancers. So if you've had a reduction, well, the first mammo you get is going to be like, this is most likely from your reduction. Then you're going to keep coming routinely. This is where the importance of that routine screening comes into play. I've picked up cancers in people that have had reduction. It's just a bit of a change from that original mammogram. So it just makes the breast look a little bit messy, but it doesn't preclude us from being able to find a cancer.
Excellent, thank you. Someone asked if this will be recorded and available after the session. It will. It will be up on our website. So compassionhouse.org/Compassion Connects. We include it there with all of our other resources. So a great tool for anyone who is undergoing cancer treatment or part of the cancer journey, including caregivers. There's a lot of great resources there. I want to say thank you so much to Dr. McKerlie for sharing your expertise in this area with us today. It was very informative and so well received. And to Karen and Marina for sharing your personal experiences. I know it's not easy to get on here and relive that, but it does do so much to help. I see a message in the chat box that says, thank you for the session. I want to get into my car and drive to get a mammogram right now. You guys are amazing. So much information. Thank you to Marina and Karen for your stories. So you guys are having a huge impact. Thank you so much. Thanks to everyone who attended today. We do have an email going out. I can include resources in that for attachments. I know people asked if they could get a copy of the slides, so I'm hoping Dr. McKerlie would be comfortable sharing that with everyone, because I think there was a lot of awesome information there. We also send out a survey just to get some feedback on how these are received, additional topics that you guys would like us to take on, etc. So if you take the time to fill those out, it does so much for us, and just continuing to get better at this. We're still pretty new to it, and obviously the Zoom environment comes with some challenges, but thank you. And then we do have another upcoming speaker series coming up on April 22nd. We are partnering with Knight's Cabin out of Calgary to do a joint session on the challenges around parenting while undergoing cancer treatment. And so I think that one's going to be really interesting. If you guys want to attend that, I will send the details out with the follow-up email that goes out as well. And have a great rest of your day. I thought the sun was shining earlier, but it's not looking so great anymore. But either way, it's an extra long weekend. Everybody enjoy it. And thank you so much for joining us.
Thank you. See you.